All right, so just recapping, just going to start from the beginning here of the heart. We said that it's a muscular pump. Its job is to deliver oxygenated blood to the tissues and pick up used blood from the tissues and bring it back to the heart, and then to be some of those wastes like carbon dioxide will be expelled through the lungs, right? And then other wastes, how is that? Other things in the blood as a result of metabolism, where does that go? So the carbon dioxide is given off through the lungs. What about the other wastes? Through the kidneys, yeah, as urine. So the big job of the kidneys and the lungs is to get rid of those wastes, or excesses that we have in the blood. So the job of the heart is just to pump things around and expose it to those major organ systems to keep the right balance of electrolytes, nutrients, and waste products, in the blood. So we want to get rid of anything that's an excess or a waste, because that could cause changes in pH, which could affect homeostasis and eventually cause death. So it's just a muscular pump is the key function. So blood pressure, every contraction of those ventricular walls, so the left and right ventricle, when they contract, they force blood out through their respective arteries, and they generate a pressure wave in those large arteries. So we make sure that we separate the pulmonary circuit from the systemic circuit. So the right side of the heart is the pulmonary circuit, so it pumps blood to the lungs. And the left side of the heart is the systemic circuit. It pumps blood to the tissues. So the right ventricle pumps to the pulmonary artery, and the left ventricle pumps to the aorta. So they're side-by-side pumps contracting together, but routing the blood in two different locations. The right side goes to the lungs, left side goes to the body through the aorta. So we want to make sure we don't have any backflow of blood as it's passing through the heart. So that's the job of the valves. They make sure that when blood from the veins enters the left and right atria, when the atria are, or when that blood is coming into the atria, the left and right AV valves are open and the ventricles are filling through the atria passively. Then the atria contract and they fill up the last of those ventricles. So about 80% of the ventricles fill by open AV valves coming and blood coming through the superior inferior vena cava and the pulmonary veins into the atria and just filling those ventricles. Then when the atria contract, they fill that last 20%. So that's what closes the valves. The left and right AV valves are closed when the ventricles begin to contract. They slam those AV valves shut to make sure blood doesn't go out the atria, and then the pulmonary valve and the aortic valve open with that increased pressure in the ventricles, and that makes sure that blood leads via the arteries away from the heart. And then as the heart relaxes, that blood kind of flows backwards in the aorta and the pulmonary artery, and that shuts those valves. So we don't want to see any backflow of blood through the heart. We always want a forward motion into the atria, into the ventricles, out through the arteries in that direction. And if we have leaky valves, we can hear that sometimes, depending how severe it is. We can hear that with a stethoscope, and that's what a heart murmur is. So it can regulate the blood supply by changing the rate, so increasing heart rate, decreasing heart rate, and increasing the force of contraction. The force of contraction in the heart we call contractility. So what would you think would happen if blood pressure was falling? Because maybe the person is really dehydrated, or maybe there's a lot of blood loss and blood pressure is falling. So that means the brain, the kidneys, and all the tissues of the body are struggling to get their oxygen and nutrients because there's not enough pressure, there's not enough flow into those tissues. What would the heart do with rate, do you think? Would it increase or decrease the rate if blood pressure was falling? Yeah, it would increase the rate, because you want to get that oxygen and nutrients to those tissues that are going to be struggling to get their needs met, to keep those cells alive, right? What would happen to the force of contraction? Would the heart beat stronger or weaker with a low blood pressure? Stronger. So that's the natural homeostatic mechanism of the heart, is to make sure blood pressure is where it needs to be. So if a person comes in with dehydration, if we take their blood pressure, what would we expect to see? High or low? Yeah, correct. It would be low. What would we expect their heart rate to be if their heart is trying to fix that? High. Exactly. What if someone has a fever and there's a lot of metabolic activity? When we have a fever, There's, a lot of activity going on in the body. What would we expect the heart rate to look like with someone with a fever? It'd be high, yeah, because the heart's working hard to supply oxygen to those cells. So those are some things you can kind of think of when it comes to the cardiovascular system when you look at patients that are coming into the ER or into the clinic, that they're going to have some of these signs and symptoms of the heart trying to fix things that have gone wrong. But what happens when a person has a high-fat diet, large body size, and narrow arteries over a lifetime of that, and smoking? Let's add smoking to the picture. What would we expect blood pressure to look like? Higher. And if the heart is trying to beat with more force to get blood through those narrow vessels, what's going to happen to the heart over time? Like any muscle, if we keep working it and working it and working it, it gets stronger for a while, but if you keep working it, it gets weaker and starts to break down, and that's what happens to the heart, is it gets enlarged, and that's called heart failure. Okay, so it's in the middle of the chest, but the apex is tilted to the left, so it's like a upside-down triangle that's tilted slightly to the left, so we can feel that apex beating against the chest wall, more on the left side of the heart. So when we're trying to put a stethoscope and get a good heart rate on a thin person, we can sometimes put that right about 2 to 3 finger widths below the left nipple to get that apex, that apical pulse. We call that the apical pulse. So if I'm giving a blood pressure medicine and I want to really be accurate with that heart rate, because some blood pressure medicines slow the heart rate. And if someone already has a slow heart rate, I don't want to give them a blood pressure med and tank their blood pressure and cause them to pass out. So I need to get a good apical pulse. So it's important that we go right over the heart and not use the wrist for a pulse, because if they have really poor vessels or maybe a weak heart, I may not feel that pressure wave down in the wrist. So we use the apical pulse, which is right over the apex of the heart. So we do it right on the chest to the left side. So the pericardium is the outer layer of the heart. There's some fluid in there, and it provides low friction. So when the heart is contracting and relaxing, it's not rubbing against the chest wall and causing irritation. But what happens if the heart is enlarged and weak after a lifetime of high blood pressure and heart failure has set in? Could you see how that pericardial or that parietal pericardium could squeeze the heart? So sometimes we have to open that sac up and allow the heart to enlarge so it's not causing damage. Some people, I had this a couple of years ago, just with a typical virus, I ended up with pericarditis. It's just sometimes a cold virus or just any old virus can settle in and inflame the lining around the heart. And it's treated with ibuprofen. It's not really a big deal as long as you catch it early. And symptoms of that is when you would lie down or change positions. I found it like when I was bending over, all of a sudden I just had this kind of pain in my chest if I took a deep breath. Or if I laid on my left side in bed, I'd have this sharp pain in my chest. But it didn't cause shortness of breath. It didn't really cause any other symptoms. It was just positional changes and ended up being pericarditis. So I just treated it with ibuprofen. It was no big deal. But if we look at the other layers of the heart, if there's infection or damage, that can be a little more serious. So the epicardium is the outer layer of the heart. The parietal pericardium is part of that. The myocardium is the muscular layer. We talked about all this in lab already. And the endocardium is that shiny, smooth inner surface of the heart, and that is what has contact with the blood. So we don't want to have damage to the endocardium. Any kind of inflammation is going to affect blood flow because that's where it's in contact with the blood. So a nice, healthy endocardium is important for blood flow. So there's these little muscles, the trabeculae carneae, that help contract and provide turbulence in the heart to make sure that blood doesn't pool. Because when blood pools, what happens? It clots. When blood sits, it clots. So if I have weak contractions of the atria because of what's called atrial fibrillation, which means instead of the atria contracting nicely and sending the rest of that blood down to the ventricles, they quiver. And atrial fibrillation are weak contractions of the atria, not enough to completely fill those ventricles, and blood pools in the atria and can form a clot. So anybody with atrial fibrillation needs to be on a blood thinner. Yeah, a blood thinner like warfarin or Coumadin or some common names of those things. And what happens is people don't listen to their bodies, and they'll have this atrial fibrillation and they won't be seen. They'll notice they have shortness of breath. They can feel their hearts fluttering a little bit when you ask them after they come in and are diagnosed. but sometimes that can lead to heart attack and stroke and kill a patient. So it's really important that people listen to their bodies and pay attention to that heart rhythm. And if they have feel like they have a fast heartbeat and a little bit of shortness of breath, be seen and take that blood thinner. And if you have like elderly relatives or people that have been diagnosed with atrial fibrillation and they're not taking their blood thinner, they're very much at risk for death due to heart attack or stroke. So looking at the heart then, there's 4 chambers. Remember, the receiving chambers are the atria, so these are the receiving chambers. So they always have veins associated with them. We have the superior vena cava and the inferior vena cava leading to the right atrium. So this is blue, meaning this is deoxygenated blood coming back from the tissues. And then we have the pulmonary veins here to the left atrium that have just received oxygenated blood from the lungs, so that's why they're red, coming into the left atrium. And then the auricles, remember, are just those little finger-like extensions that are just little extra spaces for blood to fill into the atria. So they receive blood into the heart. Then, because the AV valves are open when blood is flowing into these veins, into the heart, it flows right down into the ventricles. And then the atria contract and the last 20% of those ventricles fill. So the arteries then are associated with the ventricles because the ventricles are large muscular chambers, much larger than the atria. They're the same size. They pump the same volume of blood, but one works under higher pressure. And which side do you think is the high pressure side of the heart? The left side, yeah. So this side is the high pressure side. So when the ventricles contract, they're going to pump blood away from the heart. So again, atria receive blood into the heart, ventricles pump blood away from the heart, so they're going to pump into arteries. So the left ventricle pumps to the aorta that goes to the rest of the body and has all these little branches, and then it dips down behind the heart and continues down into the abdomen to become the abdominal aorta, and then it branches into the legs to become the femoral arteries. But the right side of the heart pumps to the pulmonary artery. And again, it's an artery because it pumps blood away from the heart, but it's blue because it hasn't been oxygenated yet. Remember, it just came into the heart via the vena cava, so we haven't oxygenated yet. So the right side of the heart has deoxygenated blood. The left side of the heart has oxygenated blood because it's already been to the lungs when it hits the left side. So the heart muscle cells themselves need oxygen. So we talked about the heart is a muscular pump, but we also can't forget about those cells need to be alive as well. So the coronary circulation is a very important circulation because if there's a clot in one of those arteries, those red arteries in the top of this slide here, those muscle cells can't do their job. They're going to starve, they'll be deprived of oxygen and nutrients, those muscle cells will die and they're not going to pump and the whole body dies, right? So the coronary circulation is what we focus on when you talk about people with cardiovascular disease and again, high blood pressure, high fat diets. What happens is there's damage to some vessel in the body and a clot forms and breaks off and gets stuck in this coronary circulation. So if it gets stuck in the, say, the left descending artery, then that's called the widowmaker, and the chance of survival is very low because most of the left ventricle is shut down, deprived of oxygen and nutrients, and doesn't pump. So where does the coronary circulation start? If you're designing this body, where is there the most freshly oxygenated blood? What vessel coming or going from the heart has the freshest blood? Which side of the heart? The left, okay. So we need a pressure force, right, to get this blood to the coronary circulation. So at the base of the aorta is where that fresh blood, a little bit of that fresh blood that's heading into the aorta, it exits via this left coronary artery and serves the heart muscle itself. So at the base of the aorta is where the coronary circulation begins. Then we need to drain this used blood from these cells that are working hard. So this is the receiving the blue. It receives the used blood from these heart muscle cells and returns it back to the heart. So we have, I don't expect you to know the names of all the veins for labs. Same thing with the arteries. Don't expect you to know all the arteries, but I would ask you in a lecture exam, the coronary circulation, the arteries, the coronary arteries begin where? What would the answer be? The base of the aorta. Very good. And then that used blood, again, flows out of the capillaries of these arteries into the veins and returns to what major vessel can we see that collects? The major vessel that collects used blood from the coronary circulation. What is it? It's a big fat vessel. Look at your diagram that you have in front of you. What's the big fat vessel there? Yeah, the coronary sinus. So that collects the blood from the different veins draining the heart muscle and then returns to where? Where does all blood go to after it's been used by the body? What's the receiving chambers of the heart, did we say? The atria. And is this used blood or oxygenated blood coming from the lungs? The coronary sinus, is that coming from the lungs? No, the coronary sinus is coming from the heart muscle. So it's going to go to what side is the deoxygenated side of the heart? The right side. And what chamber is on the right side that receives blood from the body? Yeah, the right atrium. So the coronary sinus leads to the right atrium. So the coronary circulation starts at the base of the aorta, serves that cardiac muscle tissue, drains, all the used blood then drains into the coronary sinus, which leads to the right atrium. Okay, so that coronary circulation is keeping a lot of doctors in business, and there's bypass surgery going on in hospitals around the country right as we speak. It's one of the most common surgeries across the country. It's a very serious, invasive surgery. I mean, you're cracking the chest and working on the heart, but it's a very common surgery. And we've done a good job on giving good outcomes to people with bypass surgery. But they have to change their diet. They have to take the medicines to keep cholesterol low and keep the blood thin and maintain that heart muscle. So the valves then, there's 4 valves. Remember, there's the 2 AV valves, left and right AV valves. So when you looked at our sheep heart, remember, so here's the atria above. And here's, remember they had those strings attached, the chordae tendineae. So this is the right AV valve, left AV valve. See that thick muscular wall of the left ventricle compared to the right ventricle? And here's that wall in between the ventricles. So these chordae tendineae tether those valves down so they don't flip up into the atria like an umbrella in the wind. And then at the base of the aorta, we have the aortic valve, and at the base of the pulmonary artery, we have the pulmonary valve. So those 4 valves. So it's the AV valves that make the sound of the heartbeat. So when they're closing, they make that first lub, and then when the pulmonary and aortic valve close, after the ventricles contract, that's the dup of that we hear with the heartbeat. So again, they prevent backward flow. So let's watch this animation quick, if it's still active. Hopefully it is. So go back and look at that one more time. So these are the AV valves, right? Left and right AV valves with the chordae tendineae attached. And then this one here, we can see this is the muscular left ventricle. So that's the aortic valve, because remember it pumps to the aorta. You have to kind of flip the heart around to find all those valves. And remember, the pulmonary artery is in front of the aorta when you looked at it in the sheep heart dissection and in your heart models. So this is the pulmonary valve, the aortic valve. But that sound, that lubbed up, lubbed up, lubbed up, is the slamming shut of these valves as blood increases, the pressure increases on one side of those valves. Okay. Yes, the tricuspid is the right AV valve, and the mitral valve is the left AV valve. And the way I remember...
We only have to know that's right.
Yeah, right and left AV valve is all you need to know for the lab exam. But the way I remember that, because sometimes different books talk about it differently, like if you go into your different programs, healthcare programs, sometimes your textbooks will talk about these differently. But I always remember that I put my heart on my left side, which is the left AV valve. So I think of my left mitral valve. And then right, I think of tri and right. You know, they have some of the same letters. Right and tri is on the right side. So those refer to the AV valves. But we always call the aortic valve, and pulmonary valve, pulmonary valve. Sometimes they're called semilunar, but you can just call them pulmonary and aortic. So that first sound, the lub, key thing to remember is the AV valves are closing. So you want to highlight the word AV valves. That's what's closing to sound that, get that first sound of lub. And those are bigger valves, right, with a lot of blood on the other side of them. So when you think of lub, it's a little longer of a sound than dup, isn't it? When I say lub, there's a little more vibration there. So that's those big AV valves shutting as the ventricles contract. They push blood on the opposite side of those AV valves, which shuts them. And then the dup is from the backflow. As the heart relaxes, it flows back toward the heart and slams the aortic and pulmonary valve shut. So that's the dup. And then sometimes there's a little flow into the ventricles that we can hear as the heart is relaxing and it's passively filling. Sometimes we get that third sound, but it's not typical. We listen to the first and second heart sounds is what we focus on. So if we try to listen to the heart valves, we have to move our stethoscope to the red areas is where the stethoscope would be, and that's something that a cardiovascular surgeon or doctor or physician's assistant nurse practitioner that specializes in cardiology, they would know where to put that stethoscope. So you wouldn't be responsible for that, and even myself as a cardiac, working on a cardiac floor, we don't have to assess valves. We just listen for a murmur or not, but we don't assess which valve it is. But just because of the way the chest wall is designed, it's not right over the valve. You have to kind of move off. You can see, move off of where those valves are located to hear the vibration from those valves. So looking at blood flow then, this is, I guess, the worksheet that's out there that you're going to fill out for understanding blood flow, or maybe doing an online activity with blood flow. But we can see that it begins, if we start with when, through what vessels does blood enter the heart to start the whole process. If we start out with an empty heart, you can see it all starts with the superior and inferior vena cava leading into the right atrium. Then we can see it fills the right atrium. And then from there, and it doesn't, this is actually kind of inaccurate, it doesn't fill the right atrium because it passively flows into the right ventricle. And then the atria contract to fill it the rest of the way. But then we can see the ventricles contract, the right ventricle, but the left is doing the same thing. So these are side-by-side pumps. We don't want you to think that, it goes through in this linear way. They're side-by-side pumps working together. But if we just focus on one red blood cell, it goes to the pulmonary artery, then it's to the lungs, picks up oxygen there, comes back to the pulmonary veins, which is the right atrium, flows into the right ventricle, and then the left ventricle. The left ventricle contracts, sends it out the aorta, and we begin again. So it flows into all the capillaries of the body, uses up all that oxygen and nutrients, and then comes back and starts the whole process over again. So you should be able to identify, the order of blood flow for one red blood cell, how it would make its way through the heart and to the body.
Can you make that slide available, because our bottom part of ours does it all? Yeah.
Oh, it has the animation over the top of it. Yeah, okay, sure. I can post that separately. This also shows it. So if we look at, we said the right side of the heart was for the lungs, right? So here's the superior inferior vena cava leading into the right atrium to the right ventricle. Then the right ventricle pumps it out the pulmonary artery and it goes to the capillaries of the lungs. Picks up oxygen, comes back. What are these two red vessels on either side? Pulmonary veins, yep. Brings it back to the left ventricle, down to the, I'm sorry, I keep saying my words wrong this morning. Must be a Monday. Left atrium, thank you. To the left ventricle, then pumps it to the aorta, which is behind the pulmonary artery, so you can't see that, but it goes from the left ventricle to the aorta, and then it goes up to the head, and then down to the rest of the body. So this would be like the carotid arteries here, where it goes up the neck and to the brain. So again, pulmonary circulation is the left side of the heart, and the systemic is going to the body. That's, I did it again. The pulmonary circulation is the right side of the heart, right? Because we're looking at the diagram, not ourselves. Looking at, so it's the right side of the heart is the pulmonary circulation. Left side of the heart is the systemic circulation. And again, the left side of that ventricle is going to be thicker than the right side because it's pumping under more pressure going to the tissues. So this is a really good diagram that kind of summarizes all this blood flow and shows everything in one place. So if you look at the heart, the way the muscle is arranged in the heart, you can see it kind of wraps around the heart, which is good because it provides a squeezing action. When those cells contract, it starts at the apex and almost has like a twisting motion, like you're squeezing out a wet rag, right? You would start at the end and really give it a good twist. Same thing happens in the heart. And then if we look at the rings around the valves, it really provides support because there's a lot of pressure on those valves. And you think every time the heart beats, there's pressure on those valves. Over time, they could wear out, so they're really tough. And if you remember looking at the sheep heart, if you pulled on those chordae tendineae, you could see how tough those were. Those are really tethered down into the wall of the ventricles. So there's an insulation that occurs between the cells that are generating the impulse, the action potential for muscular contraction. So there's connective tissue that forces the impulse to start at the atria, go down the interventricular septum, and then up the walls of the ventricles via the Purkinje fibers. That pathway for getting that impulse to cause contraction is created by connective tissue separations. So if we look at a typical cardiac muscle cell, if you remember this from when we studied muscle, is they are branched cells, typically with 1 to 2 nuclei. So they don't have multiple nuclei like the skeletal muscle cells have, but they do have these striations. So they have these vertical up and down lines that you can look at under the microscope, which is created by the Z discs and M line. That overlapping actin and myosin creates that nice regular pattern. And then they have those intercalated discs. Remember those dark lines that separate the skeletal or the cardiac muscle cells? Only cardiac muscle has intercalated discs. 2 things we find at intercalated discs are desmosomes, which are shown here. They're just special things that tether the cells together, so they hold those muscle cells in contact with each other. So when one shortens, it pulls the other cells with it. And we also see gap junctions, which are simply doorways. So here's one cardiac muscle cell, here's another cardiac muscle cell. So if this one has an action potential and there's sodium inside it, that sodium can flow right through into the cytoplasm of the nearby cell and cause an action potential there. So action potentials are quickly generated throughout cardiac muscle because of these intercalated discs, through those open doorways for ions to flow from one cell to the next. So intercalated discs contain desmosomes and gap junctions. Those are the 2 things we find at the intercalated disc. Again, desmosomes just tether them together, and gap junctions allow that action potential to flow. Because of those intercalated discs, when a certain part of the heart is contracting, again, it's separated by connective tissue, so we have specific hearts contracting at specific times. So both the atria contract together, and then that impulse goes down the interventricular septum, up the walls of the ventricles, and the ventricles contract together. So all the cells of the ventricles are contracting as a unit because of these intercalated discs. So we're going to look at the action potential in the heart muscle cells are somewhat different than what we saw in skeletal muscle cells. So if I look at the cells that make up the heart, the myocardium, the muscular part, 99% are cardiac muscle cells waiting for an action potential to arrive in those cells. Again, through the gap junctions and down that pathway that's separated by connective tissue. And then 1% can generate their own action potential. They're called pacemaker or autorhythmic cells. So the SA node, the AV node, bundle of His, bundle branches, and Purkinje fibers are these 1% of cells. So if I look at an action potential graph, which we saw in the nervous system, right? We already looked at this. In the muscular system, the action potential starts at -85. Rather, what was it in the nervous system? The resting membrane potential threshold was -55. What was the resting? Yeah, -70. So for muscle cells, we see anywhere from -90 to -85 for the resting membrane potential. So that's also true for cardiac muscle. So we see a rapid depolarization caused by sodium, just like we see in skeletal muscle cells. But once we get up here, voltage-gated calcium channels are present in cardiac muscle cells that keeps that membrane potential in the positive range a little longer. It's called a plateau. So we see a plateau, this little elongated positive portion of the graph where it hangs out a little bit longer, and that is the end of contraction, right? Depolarization causes contraction and repolarization is relaxation. So this allows a little more time for the atria to completely empty, or the ventricles to completely empty their blood, and prevent rapid heart rates that would prevent the time for the ventricles to fill and the atria to fill again. Because if we had rapid action potentials, that heart rate would be so fast that there would never be time for the ventricles to fill with blood. So that little plateau phase is important. So the action potential in a cardiac muscle cell takes longer than one in a skeletal muscle cell. Look at the time frame. 2 milliseconds, it's done. How long does it go on for a cardiac muscle cell? A lot longer, right? Because of that plateau phase. And again, what ion causes the plateau? What channels do we see that are triggered at positive potentials? Well, potassium, so we have sodium here, sodium here. So sodium's flowing into the cell here, same as here. Potassium's flowing out of the cell here, out of the cell here. What ion did I say was special? Calcium. Calcium. So if I have calcium imbalances, it can cause muscle cell problems, skeletal muscle cell problems, because remember the motor neuron needs voltage-gated calcium channels to get acetylcholine to dump into the synaptic cleft and get the action potential going. But we can also see heart rhythm problems too when people have calcium imbalances. So the key difference in a contracting muscle cell is that calcium plateau we see in the heart cell. So 99% of cardiac cells have this type of action potential that's shown in blue here. Calcium is flowing into the cell. Potassium is flowing out, but that calcium flowing in kind of flattens that graph a little bit, because calcium is an extracellular ion. It's always found in higher concentration outside the cell. So when you open up a door, it's going to flow in. Calcium is a positive ion, so it's going to become more positive. It's going to stay a little more positive in there, even though potassium is flowing out during this time. And then those channels close, and then you see the rapid repolarization associated with loss of potassium. So if we look at the special 1% of cells called pacemaker cells, these are clustered into the conduction pathway. We have the SA node that's in the roof of the right atrium. We have the AV node that's in the floor of the right atrium. Then it comes together at the top of the interventricular septum. It's called the bundle of His, or the AV bundle. Then we have two bundle branches coming down, and then up the sides we have what are called Purkinje fibers. So the way the impulse flows throughout the heart, and again, these cells are separated from the other 99% of contracting cells by connective tissue. So this impulse is forced down this pathway. So action potential fires all by itself at the SA node. That action potential travels across and causes the left atrium to contract at the same time the right atrium contracts. Then there's a slight delay at the AV node. Then the impulse travels down into the ventricles, up the Purkinje fibers, and once it goes up the Purkinje fibers, the ventricles contract. So the atria contract first, slight delay, then the ventricles contract. So where again, what's the pacemaker of the heart? What starts it all? The SA node. And where is the SA node located? Yep, the roof of the right atrium. So those cells have a natural ability to generate an action potential at about 100 beats per minute. But because of the parasympathetic nervous system that also has nerves going to the heart, that slows it down to about 75. So if the SA node is functioning, a person's heart rate will be about 75 beats per minute. But let's say something happens, person has a heart attack, there's damage to the SA node, it no longer functions. Will the heart still contract? Yes, because if you look at the notes on the bottom of this page in your notes packet, the AV node will take over, but at a slower rate. It can only fire off action potentials all by itself about 40 to 60 beats per minute. And let's say the whole atria shuts down and only the ventricles can pump blood. If only the ventricles are working, these fibers can generate their action potentials only at 30 to 40 beats per minute. Sometimes we have damage to this pathway in cardiac patients. What would you expect to be the problem with them then? If they have a block, it's called a heart block. If they have heart block, what's a symptom of that? When I listen to their heart rate, what's it going to be? Really low, because the ventricles are beating. They're not taking a signal from the SA node, which is saying 75 beats per minute. It's kind of setting the pace and sending that action potential down the pathway. If there's no connection between the atria and the ventricles just beat on their own, and it's going to be a 30 to 40 beats a minute, which is a really low heart rate. It's hard to be active with that low of a heart rate. If we look at action potentials with these 1% of cells, it looks a little different again, because they can generate their own action potential. There's no real resting membrane potential. What happens is when we have depolarization due to what? What's the difference here? This rapid depolarization we saw in skeletal and contracting heart cells was due to sodium, right? In these special cells, it's due to calcium. So the early depolarization before a threshold here, the early depolarization is due to sodium channels that just drift open, that as soon as the potassium channels close at the end of this downward slope, sodium channels naturally open, and it becomes more and more positive until we get to -40, and then calcium channels open up and we see a rapid depolarization. So potassium is still acting on the downward side of the action potential graph, but the early upsweep is sodium, and then the rapid depolarization is calcium. Again, but this is only in the special cells of the conduction pathway. So we see this type of graph only in cells clustered in the SA node, AV node, bundle branches, bundle of His, and the Purkinje fibers. So these special cells that are in this conduction pathway have this type of graph. And in your, some of the worksheets I posted online, you'll see there is I ask you to kind of distinguish among the different action potentials, so that's for the next activity. So we'll pick up next time talking a little bit more about the electrocardiogram and how that looks related to these graphs.